Today we will discuss second line antitubercular drugs. In the first video we talked about first line antitubercular drugs, where we talked about isoniazid, rifampicin, pyrazinamide, ethambutol and streptomycin. But as we know that incidence of multi-drug resistant and extensively drug resistant tuberculosis is increasing day by day, maybe because of exposure to first line antitubercular drugs. Many of these organisms, they are developing resistance. But now we have quite a large number of drugs in for management of MDR tuberculosis. Broadly, WHO classifies all second line antitubercular drugs into three categories: A, B and C. And this is basically done, it is not that this is based on some chemical structure or something. It is based on making the regime, because for second line drugs, various regimes can be constructed by the treating physician. So to help the treating physician in selecting the drugs, they are divided into these A, B, C. So the physician has to take one drug from each group and construct a regime according to the needs of the patient. Unlike first line drugs where we have fixed regimes, second line drugs, the regime is constructed by the treating physician as per guidelines. So in group A, that is highest priority, you have to select at least one of these drugs, that is levofloxacin or moxifloxacin, bedaquiline, and I am talking about B-PAL regime. There will be a separate session on regimes on antitubercular drugs. And third is linezolid. So these drugs are included in group A, highest priority. Group B, we have clofazimine, cycloserine. We have to take at least one drug from group B also. And group C, delamanid, pretomanid, ethionamide or prothionamide, para-aminosalicylic acid, amikacin, imipenem, silestin, meropenem, usually with clavulanate. So to complete the regimes, these group C drugs are used. We will not talk about moxifloxacin or levofloxacin. Fluoroquinolones will be covered in another session. So there is nothing specific about tuberculosis when it comes to fluoroquinolones. The characteristics, everything is same. They are DNA gyrase inhibitors. So we will start with ethionamide and prothionamide. We are not going according to the groups or importance of the drug, because for undergraduates, most of the times we have a short note in the exam. So that is not related to whether the drug is very important. So this is rather the drug that was available in 60s, 70s, and traditionally pharmacologists talk about them: ethionamide, prothionamide, cycloserine. So these are the drugs which are very old. They are thioamides, are taken up by the bacteria as an inactive prodrug. Most of these drugs in second line, they are prodrugs. So ethionamide and prothionamide are prodrugs. Inside Mycobacterium tuberculosis, it is oxidized into its active form, that is ethionamide S oxide, by the fad containing monooxygenase enzyme ETHA. This is the enzyme, monooxygenase enzyme, that converts it into active compound, that is ethionamide S oxide. The activated form binds to nicotinamide adenine dinucleotide, that is NAD, NAD+. So this will bind to NAD. This NAD adduct strongly inhibits the INHA enzyme, that is acyl carrier protein reductase. Remember, we're talking about INH. This is same. So acyl ACP reductase, this is inhibited by this. INHA is a critical enzyme in the elongation pathway of fatty acids required to build mycolic acid. So same mechanism as INH. Mycolic acids are unique and essential components of the mycobacterial cell wall. So by blocking their synthesis, ethionamide weakens the structural integrity of the bacteria, leading to cell death. So same mechanism as isoniazid. What are the uses? Ethionamide is used as a second-line anti-TB agent, typically for multi-drug resistant tuberculosis, because it shares the INHA target with isoniazid, another TB drug. Mutations in the INHA promoter region or the ETHA activator gene can result in drug resistance. So these are two mechanisms by which resistance can develop. Either INHA promoter or ETHA activator, that is causing conversion to active drug. Adverse effects. High rate of adverse effects, particularly GIT distress, liver inflammation and neurological symptoms. Gastrointestinal side effects are most common. They include nausea, vomiting, diarrhea and severe abdominal pain, metallic or sulfurous taste, loss of appetite and excess salivation. Dose related and occur in about half of all the patients. Remember, second line antitubercular drugs, they are known for their side effects. They are very toxic drugs, but we have to use them because this is a life-threatening disease. Taking the medication with food, milk or orange juice can help mitigate this. Hepatic side effects include elevated levels of liver enzyme transaminases and hepatitis, jaundice. Liver function should be monitored regularly during therapy. Actually, nowadays, if we see in second line drugs, regularly we have to undergo ECG because many of these drugs, bedaquiline, linezolid, they have this QTc prolongation problem. And almost all anti-tubercular drugs, they have hepatitis as a problem. So liver function tests are routinely done. Then important is neurological and psychiatric side effects. Depression, anxiety or acute psychotic reactions, drowsiness, dizziness, headache, restlessness and peripheral neuropathy. This is another side effect that is seen with many of these drugs. As I said, mechanism is same as isoniazid. Isoniazid also has this peripheral neuropathy as main toxicity. Same treatment that we do vitamin B6, which is 20 milligram every day. So with ethionamide also we have to go for it. Endocrine and metabolic side effects are hypothyroidism, which may cause fatigue or weight gain, hypoglycemia, gynecomastia, impotence and menstrual irregularities. Dermatological and hypersensitivity reactions are severe allergic reactions, skin rashes, acne, hair loss and photosensitivity. Other side effects are visual disturbances, including blurred vision and optic neuritis, and postural hypotension are also observed. So we can see all these side effects that makes it very toxic. Another drug is cycloserine, broad spectrum antibiotic and structural analog of amino acid D-alanine. Primarily targets bacterial cell wall synthesis in the cytoplasm, works through the competitive inhibition of two key enzymes required for creation of peptidoglycan, an essential structural component of the bacterial cell wall. That was inhibiting INH and ethionamide were inhibiting mycolic acid. It is inhibiting peptidoglycan. One is alanine racemase that normally converts L-alanine into D-alanine. So one target is alanine racemase of cycloserine. Another is D-alanyl synthetase. This is also a D-alanine ligase. So two D-alanine molecules are fused together. Cycloserine inhibits this enzyme from joining the D-alanine molecules together into the essential dipeptide needed to form the bacterial cell wall. So this D-alanine fusion is inhibited. By blocking these enzymes, cycloserine severely impairs the bacterium's ability to build and maintain a functional cell wall, ultimately leading to cell lysis and death. Because of its unique mechanism of action, cycloserine is primarily used as a second-line combination therapy for MDR tuberculosis. Now in group B, cycloserine. So it is there in the resin. Adverse effects. Most common is neuropsychiatry and dose dependent. Most common reason for treatment discontinuation of cycloserine, that is neuropsychiatric disorder. Pyridoxine routinely prescribed along with cycloserine also. Psychiatric adverse effects are anxiety, severe depression, irritability, extreme restlessness and personality changes. And the incidence is very high. Psychosis. Severe reactions include acute psychosis, paranoia, hallucinations, delusions, and suicidal ideation. And neurological. So broadly we have divided psychiatric and neurological. In psychiatric also mild and pure psychosis. And in neurological also drowsiness, dizziness, headache, tremors, muscle twitching, vertigo and speech difficulties. And severe neurological adverse effects include convulsions, paresis, hyperreflexia and in extreme toxicity coma. So grossly we can divide them into two, neurological and psychotic changes. Other adverse effects are cardiovascular tachycardia or in high daily doses heart failure also. Dermatological skin rashes, hives, photosensitivity. Rarely severe skin reactions like Stevens-Johnson syndrome is also observed. Hematological, folate, vitamin B12 deficiencies and megaloblastic or sideroblastic anemia, that is also seen. GIT and hepatic mild nausea, stomach upset and elevated liver enzymes, that is transaminase. So seen with this also, cycloserine. So these are side effects of cycloserine, most important neuropsychiatric disorders. Then third is para-aminosalicylic acid, though it is not very commonly used, but when I talk to pulmonologists, they always claim that we should always teach PAS also, because this is an effective drug. PAS is a folate antagonist used when more effective drugs cannot be used. So as a replacement, PAS is very important. Folate antagonist. PAS is a bacteriostatic agent. Stops Mycobacterium tuberculosis from multiplying through two primary pathways. One is folate synthesis inhibition. As an analog of PABA, para-aminobenzoic acid, interferes with folic acid metabolism. Either competes with PABA for the enzyme pteridine synthetase, that is also known as dihydropteroate synthase, or interacts with dihydrofolate reductase to block folate production, which starves the bacteria of essential nucleotide for DNA replication. Another is iron metabolism disruption. It's also believed to disrupt bacterial iron utilization by inhibiting mycobactin biosynthesis. Mycobactin biosynthesis, a critical step for iron acquisition in mycobacteria. So these are two mechanisms for PAS. Side effects, again nausea, vomiting, diarrhea, abdominal pain, bloating and soft stools are most frequent, 1 to 10%, and often leading to treatment disruption. So they are not mild. Other common adverse effects are skin rashes, hypersensitivity, giddiness and vestibular syndrome. Endocrine side effects include hypothyroidism, especially in patients with HIV. Serious side effects, liver damage in this case also. Crystalluria are serious side effects. Other serious side effects include fever, rash, joint pain or lupus-like syndrome. Hematological adverse effects are very rare cases of anemia, thrombocytopenia and leukopenia. Metabolic adverse effects include hypoglycemia and in rare cases malabsorption syndrome. PAS can interact with drugs like rifampicin and warfarin. So drug interaction also is there. It's a salicylic acid PAS. Then we come to the drug. Actually, if we see after a gap of almost 50 years, a new drug entered in this regime of antitubercular drugs. Otherwise, you see, after 70s there was no new drug, and then came bedaquiline. Came somewhere 12 or something. A novel antimycobacterial drug that acts by inhibiting mycobacterial ATP synthase, an enzyme essential for energy production in Mycobacterium tuberculosis. So till now, what are we talking about in ATT? We are talking about cell wall synthesis inhibition because of various mechanisms. We have talked about DNA dependent RNA polymerase in case of rifampicin. We have talked about other mechanisms. So either we are inhibiting protein or we are inhibiting the cell wall synthesis. Here, energy, ATPase is inhibited. Specifically binds to the C subunit of the membrane bound FO portion of ATP synthase. This we have to remember, C subunit of FO portion of ATP synthase. There is one more mechanism, that is another part of ATP synthase. It is found that it also binds to that, thereby blocking the proton driven synthesis of ATP. So this we have to remember. This leads to a marked depletion of intracellular ATP stores, resulting in failure of energy dependent cellular processes and eventual death of the mycobacterial cell. Unlike most antitubercular drugs which interfere with, like I told you, this is interfering with the energy. So it has a unique mechanism. This property contributes to its efficacy in the treatment of MDR TB and XDR TB. May also act as uncoupler, disrupting the electron transport chain or bind to the epsilon subunit of this enzyme. So this is another portion where it can bind. Bedaquiline is typically used in combination regimes, BPAL mainly, and requires medical monitoring for potential side effects such as QT interval prolongation. Resistance to bedaquiline can develop through two main pathways. One is mutation of ATPE target gene, which encodes the C subunit, reduces the drug's binding affinity, and other is upregulation of MMP-S5, MMP-L5 efflux pump, often driven by RV0678. Mutations increases the pumping of the drug out of the cell. So this mechanism is also seen in resistance. Adverse effects. Bedaquiline carries a black box warning. Can cause abnormal and potentially life-threatening heart rhythms. ECG monitoring is mandatory throughout the treatment. Early clinical trials observed a higher rate of deaths in patients receiving bedaquiline compared to a placebo. We don't know the exact cause. Less common side effects include potential for elevated liver enzymes and rare but possible risk of pancreatitis. The commonly observed side effects are GIT side effects like nausea, vomiting, diarrhea, pain in abdomen, and loss of appetite. Musculoskeletal side effects are arthralgia and muscle or limb pain. Neurological side effects include headaches and dizziness, and some other side effects like chest pain, coughing up blood, and rash may be observed. So most serious and most important side effect is QTc prolongation, but all these side effects are also there. Then delamanid and pretomanid. These are bicyclic 5-nitroimidazole antibiotics, representing a crucial modern class of drugs used to treat MDR-TB. Require bioactivation inside the bacterial cell to exert bactericidal effect. So this is also a prodrug. Absorbed as an inactive prodrug and relies on the mycobacterial F420 coenzyme system, specifically the diazaflavine dependent nitroreductase, that is DDN, we call it diazaflavine dependent nitroreductase enzyme. This causes activation of this drug. The reduction forms reactive intermediate metabolites which are responsible for its activity. It destroys Mycobacterium tuberculosis bacterium by a dual mechanism. One is prevents the synthesis of methoxymycolic acid and ketomycolic acid, which are essential components. I am talking about general mechanism of these imidazoles. Also releases reactive nitrogen species including nitrogen oxide, which are toxic to the bacteria. Delamanid inhibits the synthesis of ketomycolases and methoxymycolates. So delamanid is blocking both methoxy as well as keto, while pretomanid primarily inhibits ketomycolates. So this is the difference. Delamanid interrupts respiration by formation of an NAD adduct, whereas pretomanid generates reactive nitrogen species. So there are some subtle differences in the mechanism of action of these two drugs. Clinical use: highly effective against both actively growing and non-replicating bacteria because it specifically targets metabolic pathways unique to mycobacteria. That is also true with bedaquiline. Adverse effects: delamanid. So both have some differences in adverse effects, delamanid and pretomanid. A serious side effect is dose dependent QT prolongation. Mandatory ECG are needed to monitor for QT prolongation. The drug may need to be stopped if QT interval exceeds 500 milliseconds. Combining delamanid with other drugs that extend the QT interval, like all these drugs can do that, it will increase the risk. GIT side effects manifest as nausea, vomiting, diarrhea, gastritis, and abdominal pain. Neurological and psychiatric side effects also are there. They include dizziness, tremor, hypoesthesia, numbness, tingling, and headaches. And psychiatric changes are anxiety, depression, insomnia, and nightmares. Metabolic side effects include increased blood triglycerides and potentially liver toxicity. Some other side effects like muscle weakness, joint pain, hypothyroidism, and rash are also observed. with delamanid. Pretomanid, serious side effects which require monitoring, QT prolongation is there, hepatotoxicity, peripheral neuropathy. I have not talked about it with delamanid. Optic neuropathy. Among common side effects of pretomanid, GIT side effects are nausea, vomiting, diarrhea, indigestion and pain in abdomen. Metabolic side effects, decreased appetite, weight loss, hypoglycemia. Neural side effects are headache, trouble sleeping or dizziness, and some other side effects like acne, rashes, itching and dry skin. Delamanid's hallmark adverse effect, this is what I have found out. Delamanid's hallmark adverse effects are QT prolongation, particularly when combined with other drugs like fluoroquinolones, clofazimine or bedaquiline. And pretomanid's hallmark adverse effect is peripheral neuropathy, GIT intolerance and hepatotoxicity. So these are the main thing we can remember. Then we come to clofazimine. Clofazimine used to be a drug for leprosy only, but now it is an integral part of MDR, XDR, TB regimes. It's a riminophenoxine dye with antimycobacterial and anti-inflammatory properties, accumulates within macrophages. This is the quality. Mechanism: exerts a slow bactericidal effect primarily by disrupting the bacterial respiratory chain and membrane function. It acts as a competitive inhibitor of type 2 NADH dehydrogenase in the electron transport chain. By diverting electrons away from menaquinone, it starves the bacteria of ATP, again interfering with energy production, electron transport system. Once clofazimine is reduced during the respiratory interference, it is spontaneously reoxidized by intracellular oxygen. This produces toxic reactive oxygen species that damage bacterial proteins, lipids and DNA. The drug stimulates phospholipase A2 activity, causing an accumulation of lysophospholipids. These detergent-like molecules destabilize the cell membrane and impair ion transport. Highly lipophilic and can bind directly to the guanine bases of the bacterial DNA, directly inhibiting replication. So many mechanisms with clofazimine, and all are important. Reactive oxygen species are produced, phospholipase A2 activity causing an accumulation of lysophospholipids and interfering in the electron transport mechanism. Anti-inflammatory. Clofazimine provides significant anti-inflammatory benefits, particularly in managing painful erythema nodosum leprosum. It suppresses excessive T lymphocyte activity and stabilizes lysosomal membranes, reducing the release of inflammatory enzymes. It also restricts the migration of neutrophils and macrophages to sites of inflammation, bringing relief to the host's immune mediated nerve and tissue damage. Actually, when we use clofazimine for these conditions, the doses of corticosteroids can be decreased a lot. Uses: one, we know leprosy, multi-drug therapy regime, both paucibacillary, multibacillary, lepra reaction, type 2 lepra reaction, erythema nodosum leprosum. So this significantly decreases the requirement of corticosteroids. Drug resistant tuberculosis, now we have added non-tuberculous mycobacterial infections like Mycobacterium avium complex, Mycobacterium abscessus and other atypical mycobacterial infections. So there also it is used. Common side effects: reddish orange to brownish black pigmentation of the skin, eyes, sweat, tears, saliva and urine. Same, just like with rifampicin. While harmless, this can persist for months or years after treatment ends. This is the difference. With rifampicin, immediately this is gone. Dry, scaly or itchy skin and heightened sensitivity to the sun. Nausea, vomiting, diarrhea, abdominal or stomach cramping and loss of appetite. Dryness, burning and irritation in the eyes. Serious side effects: severe skin discoloration can lead to depression and thoughts of suicide. Prolonged or high dose use can sometimes cause crystal accumulation in the intestine, resulting in severe bowel obstruction, bleeding or enteritis. Rarely can cause QT prolongation also, and particularly here we are saying again and again, because there are 3-4 drugs which are doing this. So when we are using them together, we have to be very careful, both QTC prolongation and hepatitis. Long-term use can sometimes lead to diminished vision or pigment deposits on the cornea. Linezolid, synthetic oxazolidinone antibiotic, attaches uniquely to a specific site on the bacterial 23S rRNA within the 50S ribosomal subunit. In case of rifampicin, we talked about mechanism through which that was DNA dependent RNA polymerase, RPOB. So there are 3-4 drugs which are interfering with the protein synthesis in the. By binding at this early stage, it prevents the ribosome from binding to mRNA and transferring tRNA, effectively blocking the formation of the functional 70S initiation complex. If we see how protein synthesis takes place, then first of all the mRNA binds with ribosome and initiation complex is formed. So this is important because it is acting on a very early stage. This early stage inhibition stops bacteria from dividing and multiplying. Because it blocks the very first step of protein synthesis, it demonstrates no cross resistance with other classes of protein synthesis inhibitor. So grossly we sometimes say that this is a protein synthesis inhibitor, this is a cell wall synthesis inhibitor, but we have to understand what exactly is the mechanism, because that will give us an insight into whether if the resistance developed to one drug, whether this will be carried by another drug also. Like in case of isoniazid and ethonamide, it's same. So if the organism is resistant to isoniazid, this will be resistant to ethionamide also. Here it is not so. It primarily targets multi-resistant gram-positive pathogens also, such as MRSA and vancomycin-resistant enterococci. They are also sensitive to this. Prolonged use of linezolid, and naturally in case of ATT we have to use them for a long time. It is very toxic, very toxic. Actually for this only I have prepared a mnemonic, I'll show you. Hematological toxicity include thrombocytopenia, most common anemia, leukopenia, pancytopenia, bone marrow suppression, reversible. Remember, I have gone through many books, but the side effects of linezolid are given only in 2, 3, 4 lines. Linezolid, it has a long list of side effects. Neurological toxicity includes peripheral neuropathy, may be reversible, may be irreversible with prolonged use. Optic neuropathy, optic neuritis, blurred vision and loss of visual acuity. and color vision defects. GIT effects are nausea, vomiting, diarrhea, abdominal discomfort, glossitis and stomatitis. Sometimes actually I try to find out, is there any drug in the ATT regime second line which is not having these side effects? Abdominal discomfort, I don't think there is any drug in second line. All of them, they cause nausea, vomiting, diarrhea and abdominal discomfort, pain in the abdomen also. CNS effects are headache, dizziness and insomnia. Metabolic effects are lactic acidosis due to mitochondrial toxicity and may present with nausea, vomiting, abdominal pain, hyperventilation and unexplained acidosis. Serotonergic effects are because it is a reversible non-selective MAO inhibitor. Linezolid, it's a non-selective MAO inhibitor, so may cause serotonin syndrome when combined with SSRIs, SNRIs, TCAs, tramadol, meperidine or other serotonergic drugs. So this will have, and what is that serotonin syndrome? Agitation, confusion, hyperthermia, tremor, hyperreflexia and myoclonus. Hypertensive reactions may occur after ingestion of tyramine rich foods, we know all those fermented and beer and pickles, so that would lead to, just like we have in case of TCAs. In case of MAO inhibitors, in antidepressants, the major dose and duration related adverse effects of linezolid are reversible bone marrow suppression, especially thrombocytopenia, peripheral and optic neuropathy, lactic acidosis due to mitochondrial toxicity and serotonin syndrome resulting from MAO inhibition. At least these side effects we should remember. Otherwise this is the mnemonic could find out. L for lactic acidosis, I for optic neuritis or neuropathy, N for neuropathy peripheral, E for eye toxicity, Z for zero platelets thrombocytopenia, O for MAO inhibitors, L for leukopenia, I for insomnia, D for diarrhea. So these are at least some of them we will remember. So this is about second line antitubercular drugs.